It's 1 o'clock sharp, 2 o'clock Eastern time. Thank you for coming. If I could ask everyone to turn their microphones off, their audio, so we don't have any background noise. So thank you for coming. Good morning, good afternoon, and good evening. Thanks for joining this Dementia Journal Club. It's the last one of our year, so we won't start again until the fall. I'm your Journal Club host, Benedict Albensi, here at the University of Manitoba. And today we're broadcasting live from the St. Boniface Hospital Research Center. And it's really my distinct pleasure to introduce our guest today, Dr. Avi Nath, who's currently at the National Institutes of Health in the United States. And so Dr. Nath's research is focused on understanding the pathophysiology of retroviral infections of the nervous system, and also the development of new diagnostic and therapeutic approaches for these diseases. So Dr. Nath received his MD degree from Christian Medical College in India, 1981, and also completed a residency in neurology from the University of Texas Health Science Center in Houston, which was followed by a fellowship in multiple sclerosis and neurovirology at the same institution. And then he did a fellowship in neuroaids at the National Institutes of Neurological, what is that? NINDS, what does that stand for again?
Neurological disorders and stroke.
Okay, thank you. He also held faculty positions at the University of Manitoba, right here, of course, 1990 to 97. So I'm sure there's a lot of familiar people in the audience. I think that was in neurology, right?
That's correct, yes.
And at the University of Kentucky from 97 to 2002. And I was actually at the University of Kentucky as a postdoc during that same time for a couple of years with Mark Mattson. So you must have known Mark Mattson.
Yes.
So in 2002, he joins Johns Hopkins University as a professor of neurology and director of the Division of Neuroimmunology and Neurological Infections. So we're really excited to have you here today. Thank you for coming. And so we're excited to hear Dr. Nath speak about microvascular injury in the brains of patients with COVID-19. Dr. Nath, welcome.
Well, thank you, Dr. Albensi, for that very, very kind introduction. As I said earlier, I remember Winnipeg very, very fondly, and those are very formative years. And I have to thank Dr. Alan Ronald for recruiting me there, and Neelan Pillay, who was the chair of neurology at that time. And so things that we did then, we still continue to pursue. And the opportunities for developing new investigators, the variety of different types of funding opportunities, the very collaborative atmosphere, and colleagues that you could depend upon are really unique to the institution. And I think it's a well-kept treasure of Canada. Okay, so I'm going to share my screen here. And let's see, here we are. And go to the first slide. So yes, as you mentioned, so I'm at the National Institutes of Health and in the Neurological Institute here, currently as its clinical director. And these three buildings together, they form the clinical center. And this is where all the clinical activity takes place. It's a relatively small hospital, but it's 200 beds. But it's a very active hospital because every patient who comes here comes for research only. So it's a great opportunity to study natural history of the disease and do early phase clinical studies. So I want to start with this one quote from Sir William Osler. And, he's largely considered the father of modern medicine. And at that time, he was chair of internal medicine at Johns Hopkins University. And later he moved to McGill and then back to the UK. But he addressed the American Medical Association in 1896. And at that time, when he gave the keynote address, he said that humanity has but three great enemies: fever, famine, and war. And of these, by far the greatest, by far the most terrible is fever. And that holds true even today, because all the people who die from famine and war put together pale in front of the number of individuals who die from infectious diseases. And in fact, it is considered that human evolution has occurred through the process of infections, because you have one infection wipes out huge populations on the planet. A few survive, they repopulate the planet, then comes another wave of infection and wipes them out, and so on and so forth. And in the modern era, these kinds of pandemics have lots of consequences, not only on the toll that it takes on human life, but it also leads to social unrest. So as you can see here, this is from the time of the AIDS pandemic. And there was huge uproar all across the world. And they were very instrumental in changing the way clinical trials are done, the way medications are approved, the way all aspects of funding for research are dealt with. And here in front of the Washington Mall, here is this quilt. And every year they would put this quilt there, and each piece of the quilt represented an individual who had died of AIDS. Okay. Eventually, the quilt became so big that it could no longer be accommodated on the mall itself. Now, you go forwards a few years, and here, this year, this is the time of inauguration of President Biden, and the same mall, this time, there has all these flags, and each flag represents an individual who had died of COVID-19 infection. And there were 400,000 people at that time. A month later, 500,000 people had died in the United States alone. And it's estimated that in the United States, close to 900,000 people have actually died, while the official numbers are more like 600,000. And at the peak, there were 4,000 deaths per day. I mean, that's huge. A lot of other types of catastrophes don't account for those kinds of deaths, even over an extended period of time. So it far exceeds the number of people, US citizens, who died in all the world wars combined and the civil wars put together. But the coronaviruses are very interesting viruses. They are at least 7 virus strains that infect humans, although there are thousands of coronavirus strains. But what is interesting about them is that they use different types of receptors, but there are 2 that use the ACE2 receptor, which is the same one that's used by SARS-CoV-2. And I want to also draw your attention to this OC43 that uses sialic acid as its receptor. Okay. But if you look at the virus itself, it's got these spike proteins that project towards the outside. And you've all heard about spike protein because that is what is used for making the vaccines. But the virus itself is pretty large in size. It's about 28 kilobases nucleotide there, which is a positive strand RNA. Compared to that, the HIV virus has only 8 kilobases. So it is almost 3 to 4 times as big. But it's smaller than like herpes viruses. Herpes virus is about 200 kilobases in size, so they are extremely huge. Okay. Now, it uses 2 receptors. The major receptor is the angiotensin converting enzyme 2 that is present on endothelial cells. But there is also a second receptor that has been described, and that is the neurophilin. It's a co-receptor. And as you can see here in this cartoon, you have the ACE2 receptor that binds directly, and then you have the neurophilin. But if you block neurophilin, you can actually block viral entry. As new viral strains are emerging, the question that that we need to be cognizant of is that it's quite possible that some of these viral strains might mutate to whereby this becomes the major receptor. If that's the case, then neurological complications could be more widespread. So there are a lot of variants. Their names have been changing, but the most recent classification now is the alpha strain, which is the most dominant strain currently in the United States and Canada. However, there are these other strains, the South American and the excuse me, and the Brazilian strain, which is called the gamma strain. And every time the virus mutates, it actually becomes more transmissible and produces a much more severe disease. But the new strain, which is the Delta strain, which emerged in India, seems to be the most virulent of all. It is extremely transmissible. Currently, 90% of the cases in the United Kingdom are caused by the Delta strain. It is less sensitive to the vaccine compared to the Alpha strain, which and only 30% protection with the first dose and 88 after the second dose of the Pfizer vaccine. So, so it is really important that before this strain takes hold, that we are able to vaccinate large populations within the country. If you look at neurological complications, you can largely divide them into two. You have the para-infectious complication which occur during the acute phase of the illness, and then you have the post-viral syndromes, which are all the immune-mediated phenomenon. And they can occur several weeks after the acute infection. The inverted triangle means that the ones on top are more common. And so anosmia being the commonest manifestation, but there are a whole variety of other manifestations that can occur. I'll discuss them in some detail. So one of the questions that everybody wants to know is that how does the virus enter the brain, or can it enter the brain? And since there is huge amounts of replication in the nasal mucosa, can it just go up the cribriform plate into the brain? And there's this beautiful study from Canada from Pierre Talbot. And what he did was, now he used this strain, which I wanted to, if you remember, I pointed out the OC43. It uses sialic acid as a receptor, not ACE2. And so what he did was made it into a fluorescent virus, instilled it into the nasal cavity of a rat, and then imaged the animal every day using an optical scanner. And these numbers here represent the days after inoculation. Okay, so what he shows is that here's day 3, you can start to see some virus going down to the base of the brain. And then by day 5, you can see all along the brainstem, the virus is present there. In fact, it turns out that between the olfactory nerves and the brainstem, there's only one synapse. So 2 neurons, and you're right there into the brainstem very quickly. The concern is that if it reaches the brainstem, then you have a lot of important structures here. And the pre-Bodzinger complex is one that controls respiration. And is it possible that you can get respiratory compromise because the virus is going to come in proximity to it? There is also the vagus nerve that is here, and again, right next to the pre-Bodzinger complex. And the vagus nerve innervates the GI tract as well as the respiratory mucosa. And those are 2 other sites where the virus replicates in large quantities. So it's, one possibility is that if the virus could travel up these nerves, especially the vagus nerve, then you could get a central hypoventilation syndrome. But evidence for that with SARS-CoV-2 is still, at least conclusive evidence, is still lacking, although a lot of people have been commenting upon it and looking for that possibility. So what would happen is you'd get this condition called Ondine's curse, which is also called central hypoventilation syndrome. And this is a fictional story whereby Ondine, who was a mermaid, and she, at the time when she was getting married, she asked her uncle, who was the king, to cast a spell on her future husband that if he were to ever deceive her, he would die. Sure enough, when she comes back from a honeymoon, her husband finds his first love, and she gets upset. She leaves the kingdom, and some fishermen find her, bring her back a few months later, and the day she comes back, her husband was getting married to his first love. He notices her, walks up to her, and says something strange has happened to his body. He has to command it every time in order to breathe. And then the 2 kiss, and he dies. So what the story implies is that while he was kissing, he was unable to breathe, and what he had was really central hypoventilation syndrome. Okay? So it's called Ondine's curse, because the pre-Bodzinger nucleus is very sensitive to changes in CO2. And if it loses its sensitivity, then the respiratory drive doesn't occur. So, but with SARS-CoV-2, the problem is that the receptor ACE2, which is the receptor for SARS-CoV-2, is not present on the olfactory nerve, but rather is present on these cells here called the sustencular cells. So they're adjacent to the nerve, and they are the ones that get infected. Now, certainly by this infection, you can get inflammation, can compromise the nerve, but there's no evidence that the virus directly goes through the nerve. Okay. And here you can see in this electron micrograph, all these black dots here are viruses, viral particles, and they are coming out of the nasal mucosa here. And this German study looked for virus in the olfactory mucosa. Certainly you can see a lot of it. They looked at the olfactory bulb, and you can see a little bit in 3 individuals only, and the rest of it is all negative. So very few individuals, small amounts of virus is all they could demonstrate. So certainly doesn't look like that's a major route of viral entry. Okay. However, if you look at the olfactory bulb and by MRI scanning, you can see, so this is what a normal olfactory bulb should look like on the right side, okay? But this is swollen over here. So there's swelling of the olfactory bulb. So that is now beyond the cribriform plate. So the question is, why is the swelling occurring here? Obviously, there must be some connection to the nasal mucosa, but if the virus is not going up, is it possible that just the viral proteins go there and do it? And that remains a question that still needs to be answered. So we tried to address this question. We conducted an autopsy study. We've done a total of 40 autopsies, but we've published the first 19. And so, but they're interesting individuals. 11 out of the 19 had died suddenly. So most of these brains came from the New York Medical Examiner's Office, and they received these bodies of individuals who had died, were found dead at home or found dead in a subway. One guy was just playing with his sister and just dropped down dead. So, so these individuals had never sought help from any physicians because they either had no symptoms or very minor symptoms that didn't warrant a trip to the doctor's office. However, at the time of death, they were all positive for SARS-CoV-2. So they had active infection. Their lungs had minimal involvement. There wasn't much there. But when we looked at the brains, we were very surprised. What we found was that we did postmortem MRI scanning on these brains, and we found that 10 out of the 13 that we had scanned had evidence of microvascular injury. We then took those 13 and did histopathology and found that you could confirm that there was microvascular disease on both on MRI and on histology, and I'll show you the type of microvascular involvement. 13 out of the 19 had perivascular macrophages, and 8 had lymphocytes. So again, the predominant cell type, infiltrating cell type or macrophages, not lymphocytes. Okay, which is different than what you would expect if it was an active viral infection. If that was the case, then you would see more lymphocytes instead of macrophages. And then 5 cases showed neurophagia. That means that the macrophages were chewing up the neurons in the brainstem. Okay, so this is what the MRI looks like. We took the olfactory bulb here and put it through an 11.7 Tesla scanner. So these are fixed tissues. And we took 25 micron sections through it. So the amount of MRI time it takes is overnight just to do an olfactory bulb. But the advantage of doing that is then we could identify areas of abnormality. So we found an area of abnormality here. We did immunostaining here. And what we found was that there was fibrinogen that was leaking into the parenchyma. So all this green U here you see is all fibrinogen. And when we stained for collagen 4, which stains the basement membrane of these blood vessels, we could see that there were areas of compromise. Okay, so there's decreased staining here wherever you see these arrows, and that's where you see the most of the leakage of fibrinogen. When we stain for various cell types, as you can see here in the olfactory bulb, there are a lot of macrophages. There's a huge number of macrophages here and here all over the place. So massive amount of macrophages. We look for the virus in many different ways. We did immunostaining, in situ hybridization, PCR analysis, RNA-seq. We didn't find any virus. Okay. Then we looked at the brainstem. As you said, we were interested in trying to see if there was any evidence of injury to the various nuclei in the brainstem. And so here again is a MRI scan done on an 11.4 Tesla scanner. And here we took 100 micron sections from the entire brainstem, going from the medulla all the way up to the midbrain. And you can see the beautiful anatomy here. Each of these nuclei can be seen. So then we took sections from each one of them and looked at them after immunostaining. Immunostained them for CD68, which stains the macrophages and microglia. But you can see in each of these nuclei, you have activation of these microglia. And here's the pre-Botzinger complex. You can see a lot of activated cells here too. But what is important is that in this pre-Botzinger complex here, you can see the neurons are atrophied, okay? And you have these macrophages around them, suggesting that there's the phenomenon of neuronophagia, that they are actively causing injury to these neurons. Again, here you can see by immunostaining, here's a blood vessel, and around it, there are a lot of macrophages here. Also in these perivascular regions, you can see a lot of astrocytosis. So this is immunostaining for astrocytes. There are a few T cells, as I said. Here are CD3 T cells. Interestingly, they're all adjacent to these endothelial cells. So it looks like they're recognizing something in the endothelial cells, or they're right outside the endothelial cells here. And you can see CD8 cells here too, just in and around these blood vessels. So besides that, you can also have cranial nerve abnormalities that can occur, and not just the olfactory nerve can be involved, but others can. In fact, almost any cranial nerve can get involved in these patients. And you can see inflammation around those nerves here. This is around the third nerve here. This is the second nerve. And this is L5 over here. So there's inflammation along all these nerves. That what they are actually recognizing there is not entirely clear. The major target, however, of the virus are these endothelial cells. So patients can develop, and they can affect the large blood vessels as the small blood vessels. So if it affects the large blood vessels, you can develop strokes. This individual has bilateral infarcts, which is extremely rare otherwise. And they can also get multiple organs involved. And so the kidney can get involved. You can get pulmonary embolism at the same time. You can also get venous and arterial infarcts at the same time. So it can be quite complicated. Here, this individual has a lot of micro hemorrhages. And then these are tissues that we looked at. You can see a microhemorrhage here in the cerebellum. And then these hyperintense signals represent inflammation within the brain. While these dark hypointense lesions represent micro hemorrhages. The other interesting thing is that you can see infarcts. So this is an infarct, and you can see microhemorrhage, and you can see inflammation of the blood vessel, all in the same individual. So it becomes extremely complicated. You got 3 types of vascular pathology in the same individual at the same time. It's a management becomes a big problem. And this is a very interesting finding here. So our MRI researchers they're looking at this brainstem, they pointed out to me that if you look at this one single blood vessel here, you'll see 3 different types of pathology in the same blood vessel. So the good thing about MRI is they take sections one way and they can reconstruct them in different planes. And since they take 100-micron sections, they can look at very exquisite anatomy here. So if you look at this blood vessel, the vessel wall is hyper intense, suggesting it's inflamed. Inside the blood vessel, you see this little clot sitting over here. And then you look at the same blood vessel in a different plane, and you see this hypodense lesion outside the blood vessel, suggesting a microhemorrhage. So you have inflammation of the blood vessel, you have a blood clot and microhemorrhage, all within the same blood vessel itself. If you look at these blood vessels under the scanning EM, and this is from the lung, and this is what the normal architecture should look like. And here you can see the blood vessels are all collapsed. And if you look at the endothelial cells in the capillaries, you can actually find virus coming out of them. So the primary target are these endothelial cells. So here again, we looked at the brainstem first by MRI scanning and then by immunostaining. Here, the brown stain is all fibrinogen. So what I want to show you is that all the fibrinogen is around these blood vessels here. And the more intense staining is certainly here, and then it diffuses out into the periphery. So each of the blood vessels has increased staining around them. Also, we were interested in platelets because these patients do develop blood clots. And so when we immunostain for the platelets, we found this very interesting phenomenon. You see a lot of activated platelets, but all these activated platelets are in close proximity to the endothelial cells. Okay. Now this one here is totally clotted, but if you see these blood vessels here, you can see they're sitting right next to the endothelial cells here. In fact, here the entire thing is sitting next to the endothelial cells. Here at the bottom, you can see nice staining for platelets here, and these 2 branching blood vessels are totally clotted. So what it suggests to me is that once the endothelial cells are activated, they then interact with platelets and cause activation. And so the primary pathology is still in the endothelial cells. Secondary activation is of the platelets. Now, to complicate the picture, there's this paper from University of Michigan, and they looked at autoantibodies in patients with COVID, and they showed that you can find antiphospholipid antibodies, but they took these antibodies and then injected it into mice and showed that they are prothrombotic. So they certainly are a physiological consequence. Okay. And in children, what you can see is an inflammatory syndrome called MISC. And here you can see a hyperintense signal in the splenium of the corpus callosum. But usually what happens is that these patients have an acute infection, and as they're recovering from it, then they start becoming encephalopathic. They can get generalized weakness, multiple organ involvement, dysarthria and dysphagia. They have inflammatory markers that are increased. These patients do respond well to dexamethasone and IVIG. So it's important to recognize it and treat them accordingly. Some patients can also develop myocarditis. So one has to be cognizant that the symptoms that sometimes look like neurological may actually be coming from someplace else. And it can occur not just with the infection, but also with the vaccines. There are several types of encephalitis that can occur in patients. So you can get a viral encephalitis, but that's extremely rare. There are only 1 or 2 cases in the literature. Most often what you see is an acute disseminated encephalomyelitis. And in some patients, you can get this acute necrotizing hemorrhagic encephalopathy. The difference between the two is important to recognize because ADEM is largely a T-cell mediated phenomenon, while the hemorrhagic encephalopathy is largely a cytokine mediated phenomenon. And you can see on this MRI scan, it usually starts in the thalamus and then spreads out to involve other parts of the brain and is bilaterally symmetrical. You can see blood here in the middle of the thalami. The other thing is some patients will have a lot of punctate lesions, inflammation in the brain. It can last for many months. Okay. Okay, so let's just go over this slide here. So some patients can also develop a myositis, and you can see, and it can be quite severe. So it can involve both proximal and distal muscles. And here on this MRI scan, you can see necrosis of the muscles themselves, and you can see inflammation between the inflammatory infiltrates between the muscle fibers. Okay, and the important thing is that they will respond to treatment with corticosteroids. Okay. Now, the important thing about the patient population that we're going to be seeing now are a lot of patients with this so-called long haul COVID. And anywhere from 10 to 30% of individuals 6 months after infection continue to complain of a large number of systemic and neurological manifestations. And it's hard to characterize them, but they overlap with what we call is chronic fatigue syndrome, although there are some differences. But you can largely classify them into 3 different groups. Okay. So one that have predominantly fatigue and headaches. These individuals complain of exercise intolerance. So there was one cardiologist I talked to, and what she said was that every time she even took one flight of stairs to get into her office, she got so wiped out she had to lie down. She couldn't even do telemedicine any longer. And since she was a cardiologist, she had all kinds of cardiac workup done, and they couldn't find anything wrong with her. Then there are individuals who complain of brain fog, and that's cognitive difficulties, but they also may have anxiety, depression, and rarely they can have a first episode of psychosis post-COVID. And the type of cognitive abnormalities they describe are also quite interesting. They have difficulty remembering time, but they can remember objects. For example, a person told me that they could remember what they ate for breakfast. What they couldn't remember is when they had breakfast, and was it today, was it yesterday, or was it a week ago? The depression and anxiety can be quite devastating as well. And so there's one person I've known who works with me known him for 10 years as a calm, quiet person, developed COVID, and then developed anxiety that he could not control. And it was just really phenomenal. We had to admit him to the hospital to control his anxiety. Finally, his anxiety is under control, but it surprised all of us, including his family, because there was no reason for him to become so anxious. There's another person who works at NIH, and he was an older individual with no prior psychiatric history. And all of a sudden, he says he got afraid that he was going to hurt himself. So he admitted himself in the hospital, and he was there for a month. So he had these suicidal ideations. And again, he says there was no reason for him to feel depressed or to hurt himself. So it's very important to recognize these complications and provide them adequate treatment, because otherwise they can be quite devastating. Then there's this third group of individuals who develop dysautonomia, and this subset of them satisfy the criteria for POTS. And what they describe is this heart racing, and every time they stand up, they get tachycardia, sometimes just lying down also. One individual I talked to, she said that she would get dizzy every time she stands. She's a neurologist. And she said that she had to talk to me lying down, because even if she sat up, she would get dizzy. We ultimately treated her with IVIG. She actually got better. But it can be quite significant postural hypotension. Some patients will get persistent fever, low-grade fever. We think that is also due to autonomic dysfunction. And there's a fourth group that you can say that they develop largely pain syndromes, chest pain, joint pain, or fibromyalgia type picture. This occurs largely in women, 4 times more in women compared to men. Average age is around 40 years. And these are the other types of autonomic symptoms: tachycardia upon mild exercise, night sweats, temperature dysregulation, gastroparesis, constipation, and peripheral vasoconstriction. They present with a Reynolds type phenomenon. And here, these are a couple of patients in the literature from Sweden, and they show that here, as this patient stands up, their heart rate goes up and the blood pressure comes down. So that's classical for POTS. But then there are these other patients who get an erratic change in their heart rate and in their blood pressure too. Can go down and then come up, and you can see the difference between the systolic and the diastolic pressure can be quite high. So then now we started seeing complications from the vaccine. Yeah. So these are the first 32 patients, but we have close to 70 or 80 patients now that we have seen here at NIH. And they're, again, mainly women. And it's occurred with all the vaccines: the AstraZeneca, the Moderna, the J&J, and the Pfizer. Mean age is, again, about 39 years. Occurs usually 2 to 14 days after vaccination. And about a third of them, it was 2/3 of them after the first dose, and a third of them had dysautonomia. So what I want to point out to you is that they not only had dysautonomia, but also have a sensory peripheral neuropathy. So they occur together in these patients. So it's an interesting phenomenon because it suggests small fiber involvement, but involves both the sensory fibers and the autonomic fibers. And there was a small subset of individuals who also developed trigeminal neuralgia, plexopathy, and paresthesias on the face. Most people have been hesitant to treat them with steroids because they feel that, oh, maybe it'll get better on its own, and we don't want to negate the effects of the vaccine. But untreated, you can see that only 2 of the patients really had a complete recovery. Some had partial recovery, and 7 of them had no recovery at 10 weeks. The ones that were treated with corticosteroids, you had complete recovery in 4, and 2 had partial recovery. So although this is not a controlled study of any sorts, it's all observational, but it still points to the fact that maybe treatment with corticosteroids is a reasonable approach in these patients who develop complications from the vaccine. Some patients will also have decreased glucose uptake in the brain, and in fact, the subacute phase, you can see decreased glucose uptake here compared to the normal individuals, and these are averages of all the other patients that they put together, suggesting that there is diffuse involvement of the brain on both sides. And I mentioned earlier that the way these graphs are plotted, this is data from the National Health Service in the UK. And what they did was they took patients who had influenza and those that had COVID and compared them together over a period of time. And what you find is that for all these psychiatric disorders, they're much more prevalent in individuals who had COVID compared to those that had influenza. And this is 3 months out. But the large sample size is, you have about 25,000 in each group. And then they did a follow-up study, and here, this time they have 200,000 patients in each group. And what they found was that all complications were much greater in patients with COVID compared to other respiratory illnesses. And this one is quite striking because what they show is that the neuromuscular diseases, which must include peripheral neuropathies, are much higher in the COVID patients compared to respiratory illnesses. So what mediates these things? And I showed you evidence for macrophage involvement pathologically. And this is a study from Germany, and they did single cell sequencing, and they compared here these neuro-COVID patients compared to those who have benign intracranial hypertension or pseudotumor cerebri. And they found just one cell type that really differentiates them. And they call it mono2, but what it is these are poorly differentiated macrophages. They're extremely aggressive macrophages. And they produce all kinds of cytokines and stuff. But that, coupled with the fact that they found decreased interferon responses and increased T-cell exhaustion, suggests that the immune responses against the virus are impaired and the innate immune responses are activated. And these innate immune responses are very poor in getting rid of the virus. So they probably result in a lot of damage to the host. The group at UCSF has demonstrated some autoantibodies also to CNS antigens, but they haven't quite characterized what those really are yet. So how should we treat these patients? Currently, we have no antivirals. There was a lot of hope put on hydroxychloroquine, but a few $100 million later, found out that that really didn't do anything. And so the opportunities are either we can suppress the immune system, but if you already have T-cell exhaustion and impaired interferon responses, maybe you don't want to broadly suppress the immune system. You want to find out what arms are activated and suppress only those arms. If there is T-cell exhaustion, maybe you can reverse it. And there are all these checkpoint inhibitors now that are available to reverse exhaustion. So that might be a possibility as well. So I'll stop here and acknowledge a few people who did all the work. So we got all these specimens from Dr. Folkert, who was in the New York Medical Examiner's Office, and 3 brains were provided to us by Marco Hefti at University of Iowa. Daniel Pearl, who is at Walter Reed, read a lot of the pathology for us. And Eliezer Maslia, who was also a neuropathologist, looked over the slides with us. And Mingwa Ali did all the immunostaining. Venshu did all the viral detection assays. And Dragon also did all the multiplex immunostaining. And Govind did all the MRI scanning. And access to them was provided by Alan Koretsky. And this is our clinical team now, so we have a lot of patients that we're bringing in and evaluating them. And the 2 lead investigators are Brian Wallet and Brian Smith. And David Goldstein does all the autonomic testing. Amanda is our research nurse, and I have 2 clinical fellows that are looking at these. So I'll stop here and take any questions if there's time.
That was great, Dr. Nath. Thank you very much for that. Some questions are already coming in for you. So I'll just ask you the first one I see here. This is from Dr. Don Davies. He says, thank you, Dr. Nath, for the great talk. Are there different neurological effects among the variants of COVID-19?
Don't know the answer to that yet, but we should look out for it. It's quite possible that there may be, at the moment, we don't have no idea.
Okay. So I was wondering, at the beginning of the talk, you started talking about the one MRI scan of a brainstem, and there were 3 pathological findings. You saw blood clot, you saw inflammation, and you saw the microvascular alterations. And it sounded like you were surprised at that. So is this something that's unique to COVID-19? You don't see this in other types of infections?
Yeah, so the closest that comes to it is Ebola. We looked at Ebola patients, and then we had a macaque model of Ebola, and that also infects endothelial cells. And there we saw both infarcts and hemorrhages at the same time. We didn't see much inflammation with Ebola, at least at the blood vessels. So that's a little bit unique to COVID. But yes, viruses that infect endothelial cells can certainly do it. They can mimic this kind of pathology.
Okay, I see another question popping up here. I'm not exactly sure who this is from. Did you examine the amygdala in the human brains, and did you label for any amyloid or tau?
Yeah, no, I haven't done any of it yet. I'd like for people to do it. I think it's a very important question.
That was for me, Ben.
Oh, yeah.
Brian.
Hi, how are you?
Valen.
Yeah. Yeah. Well, thanks for asking that very important question.
Excellent talk.
Yeah, well, thank you so much. And it is really important, and it would be, especially considering the fact that a lot of elderly people succumb to the infection. Yeah. So the relationship of that to amyloid and tau would be really important to know. Is it possible that this inflammatory process could accelerate protein aggregation? That would be our hypothesis,
Yeah. Thank you.
Okay, I see another question popping up. This is from Kelly, Dr. Kelly McDonald.
Oh yeah, Kelly.
And
Kelly.
asking about, I'm not sure if I'm
testicular cells. I can see her.
Okay, you
right
see
here.
it. Okay, very good.
So let me first of all say hi to Kelly. So I remember her very fondly. She and I were together in Winnipeg, and so I hope she's doing well. And thanks for attending the talk and for asking this question. So she says that since the testicular cells are infected only in the olfactory mucosa, only why are the neural cells knocked out? So yes, you're right, Kelly. I think what is happening is there's enough swelling, and the infected cells release all kinds of other toxic substances. So the cells in vicinity will die. I mean, the same thing was true with HIV infection, for example. If you remember, we had a lot of infected macrophages in the brain, but the cells that were dying were neurons. They were never infected. So you can have a lot of bystander pathology. And she has a follow-up question saying, also have specific innate checkpoint inhibitors being used. So we haven't used it, but we are putting together a clinical trial right now in which we want to use pembrolizumab in some of these long haul patients, but we will do it very carefully. We want to, first of all, make sure we do flow cytometry on the cells, show that PD-1 is actually elevated, and then we'll give it and then monitor it to make sure it meets its target and has an effect. So it's still being designed. Yeah.
And it's Mark Delbijo. Can I just make a
Hey,
comment?
Mark, how are you?
Hi, Abby.
So good to see you.
Yeah, me and Kahal beside me. Anyway, I was sort of at American Association of Neuropathology meeting last week, and there were eight papers presented from mainly big groups in the U.S. who've been doing autopsies, and with the exception of one of them who found sort of in a small number of patients a bit of PCR signal in brain tissue. They basically all concluded that this is not a neuronotropic disease. It's all vascular disease. Regarding Kelly's question, there was a paper at the meeting about examining the olfactory region, and those authors concluded that it's a olfactory axonopathy. That's it's, as you say, it's a bystander damage related to inflammation in the mucosa. So it's not so much that the olfactory bulb neurons are dying off, but the penetrating axons are getting hit.
Yeah. Thanks. Yeah, that's very helpful. And I'm glad that we're not the only ones who didn't find the virus. When you don't find anything, you don't know, you just miss it. But if a lot of people cannot find it, then it does mean that certainly if the virus gets there, it's a very small amounts. It can't explain the pathology, that's for sure. Yeah. Which in a way means that you should be able to develop a mechanism of treating these patients. Yeah, in the absence of whatever.
I think we have our next question from Nikki. She got skipped over. Nikki, did you have a question?
Yeah, I did. Dr. Nath, thank you so much. It was an excellent presentation. So one question I had for you, and maybe it's more for you and your colleagues that you talk with as we accumulate these findings with this new virus, has this sort of infectious, also immune response led you to think a little bit more about the etiology of other neurovascular diseases or cerebrovascular events that take place in patients with regard to other pathogens that may be neurotropic?
Yes, I mean, that's, nature has very few simple laws, right? So it doesn't develop unique mechanisms for each virus. So they're always common mechanisms. So if you study one, it is usually can be extrapolated to other viruses. So just as I mentioned, all viruses that infect endothelial cells or can cause vascular damage. Dengue being another one out of the flaviviruses, cause a lot of vascular damage. So they have common themes. And so certainly if you study one, you'll learn about the others. That's absolutely true.
Okay, very good. Other questions out there? Oh, here's one from Ida Adlimigadam, Dr. Adlimigadam. Great talk, Dr. Nath. Did you measure the glucose uptake rate in the olfactory region of patients with COVID?
Yeah. No, so I think that would be good to do if somebody could do PET scanning and really focus in that area. The problem with PET is with glucose PET is that the resolution of PET is not that great, but it doesn't mean it cannot be done. It's just not easy to do. But if it could be done, I think that would be actually very helpful. So that's a reasonable thing. But there's a lot of structural MRI that people have published in that region showing pathology there. So I wouldn't be surprised if glucose uptake will also be similarly impacted.
Nikki, I see your hand is still up. Did you have a second question?
Sorry, no, that was it. I'll take my hand down.
Okay. Okay. All right. So, okay, well, very good. I don't see any other questions right now. Oh, wait, here's one from Dr. Anderson, Judy Anderson here. I think this is a recent question. A lovely talk, Dr. Nath. Would you think it's possible there would be a wave of post-COVID syndrome from those that recover from long haul problems?
Yeah, I mean, the problem with the long haul is that they're not recovering. There are very few people who do recover, and most recovery occurs within the first month or so. And by the time they reach 6 months, if they haven't recovered, it's usually just long lasting. And so if it is true that the numbers are 10 to 30% of individuals infected are still symptomatic 6 months later, then we have a huge problem on our hands. So even if you have an effective vaccine and everybody got vaccinated today and we had no new cases, you still have hundreds of millions of people who will have these long-term symptoms. And if you don't do anything about it, they have a lifespan of another 40 to 50 years, right? So you're going to take out a huge workforce and out of whatever they're supposed to be doing, taking care of families or working, and the consequences of that are just unfathomable. So we have a huge problem on our hands.
Another question, I think this again is from Kelly McDonald. I'm not 100% sure. What is the prevalence of complications post-vaccine with myocarditis and neurocomplications? Do you see this causing vaccine hesitancy?
Oh, yeah. That's a very good question, Kelly. So the way I answer it is that, yes, myocarditis can occur. There are a number of other complications. I showed you a whole slew of them that can occur with these vaccines. And as you know, almost all vaccines have some complication rate, right? But the reality is that even if there is there's nothing to fear. And the thing is that what if you got the infection instead? I mean, currently we're just injecting a small amount of this spike protein. And if you never got vaccinated and now you get infected, well, you're going to develop not only the complications you were going to get from the vaccine and more, because you got fully replicating virus there. Nobody's dying from the vaccine itself, but you will die from the infection. And if you develop a complication from the vaccine, it's likely treatable with some corticosteroids or IVIG or something of that nature. So I would, even if I knew I was likely to develop a complication from the vaccine, I'll still take the vaccine and treat the complications.
Okay, very good. I see another question from Victoria. Victoria, did you want to ask your question yourself? I don't see anything in the chat box.
Oh yeah, thank you, Dr. Nath, for that very interesting talk. So I was actually wondering the average age of these patients whose brains were examined. So I was wondering that because if we know the past medical history of these patients, if they had, for instance, high blood pressure or high cholesterol level, or even smoking, which are known risk factors for, vascular diseases and all that stuff.
Yes.
So was there a consideration of their past medical history? And do you think that there's a contribution of these other risk factors to the vascular findings that were reported in your study?
Yeah. So in our study, the problem is the history was kind of limited. A lot of them were relatively young, actually, who died. So likely they didn't have long-standing history because, you know, they were, when they show up at the medical examiner's office, usually you don't have much to go by for history because they're not coming from hospitalization where you've collected all the history on them, right? And the grieving family, it's hard to go back and get that kind of history. But you're absolutely right. If you look at other autopsy series and the patients who have died, who have those people who had pre-existing conditions, either any vascular risk factors or kidney problems or heart problems, they were most likely to, and the mortality rates were extremely high in those individuals. So you're absolutely right that 1 and 1 doesn't make 2, 1 and 1 makes 3. That becomes synergistic.
Okay, thank you. Well, we're coming to the close of our hour. We have time for one very quick question. I don't see any questions, but maybe one more question if anyone has it. I want to thank you, Dr. Nath, for taking your time to do this today. I mean, as you can tell, there are lots of great questions, and not only was it a great presentation, but such timely information and so important for so many people. So thank you for that. I don't see any other questions, so maybe we'll just cut it off here. Have a great weekend.
Oh, well, thank you for having me. It was a real pleasure. Yeah.
I see someone popping up, or maybe they're just waving. They're waving goodbye. Okay.
Hi, Jim. Good to see you.
Okay, well, thank you again, Dr. Nath. Take care, everyone. And we'll see you next fall.
Good to see you too, Avi.
Yeah, likewise.
We both aged well, huh?
No, you still looked as young as I remember you.
You either. Great talk. Thank you.
Oh,
Loved it. Loved seeing you too.
Coming. Yeah, great.
Thanks for hosting,
Kelly.
Ben. Nice to meet you, Dr. Nath. Take
Yeah,
care.
likewise. Good
Okay,
to see
thank
you,
you,
Kelly.
everyone. See you next
Bye.
fall. Okay, bye-bye.
Okay, bye-bye.